Okay, so today we are, this is pretty much our last content lecture, Yippee Skippy. For those of you that are listening, I was looking at my number of views and I was a little bit sad. I do understand that you're all kind of crunched for time, and maybe just the best use of your time is to read through the PowerPoint and read through the materials. But I feel a little bit better, I guess. I'm hoping that this is helping. Maybe it's not, but trying to explain things a little bit better. So I guess you have to take it for what it is. So just so you don't freak out, there are 72 slides on this particular PowerPoint. However, there's a lot of repetitiveness. Okay, so there's like a step-by-step process that we look at when we're evaluating the heart blocks. So you know, just kind of keep that in mind. So I promise I'm not going to spend several minutes on each one. Alright, so a heart block basically is when there's something that's impairing the impulses to travel basically through the heart. Okay, they can happen at the AV node, these blocks, bundled His or bundle branch blocks, complete heart block. Obviously can be associated with hypotension, but some other milder forms really don't even cause symptoms. So they basically occur when the impulses start in the SA node and are blocked or delayed. Okay, it can also be delayed in the area of the conduction system. So the seriousness of the heart block basically has to do on the patient's overall clinical appearance. And it can really vary. Alright, so the first one we're going to talk about is first degree heart block. Okay, so first degree. So this is the analogy of, I sent a couple of a poem, and then there's also the little story. Okay, so I'm going to kind of talk about the story at the same time. I think I'm going to read through the poem, okay, and then I'll kind of break up like the story. Okay, so the heart block poem. The R is far from P, then you have first degree. Okay, so that's basically your delay. Okay, longer, longer, longer dropped, meaning the P to R interval. Then you have Winky Bach. Some P's don't get through, then you have Mobitz 2. If P's and Q's don't agree, then you have third degree. So that's a little poem. But I kind of like the little story. So the story goes, you have the P wave is the wife, and the QRS is the husband, and the pacer is counseling. Okay, so in normal sinus rhythm, the wife, which is the P wave, waits at home for the husband, the QRS, and the husband, the QRS, comes home on time every night. Okay, so that's normal sinus rhythm. Everything's jiving really good there. Okay, first degree heart block, the wife, which is the P wave, is waiting at home, and the husband, which is the QRS, comes home late every night. But he always comes home, and it's at the same time every night. However, it's a delayed time. He's coming home late. Okay, so that's your first degree heart block. Okay, so it's characterized by a PRI, or PR interval, greater than 0.2 seconds. Okay, so that is first degree, and we're going to take a look at it several different times here on this PowerPoint. Okay, so we kind of go through this whole checklist basically. Our rate can be between 40 and 100, our rhythm is regular, our P waves are there. The only thing that's really abnormal is our PRI. It is prolonged. Okay, our QRS is also normal. Okay, so this is really truly more of a delay than a true block. Okay, so this is usually a minor AV conduction defect. The P's are always related to a QRS. However, you want to notify the physician if you're noticing that the PR interval is lengthening. Some of the causes, sometimes it can be found in young athletes. It also might be from certain medications such as beta blockers, calcium channel blockers, digoxin, or an acute inferior MI. Okay. So we're looking at this rate here. This rate looks to be about 60. What is the rate? About 60. So you got 6 QRSs. So 6 times 10. The rate, is it regular? Yes, the rate is regular. And these are the questions that you ask yourself. Are there P waves present? Do they look pretty? Meaning, are they normal? Are they upright? Are they about the correct size? Is there a P for every QRS? Is there a QRS for every P? Do all the P waves look like each other? And is each P wave the same distance from the QRS? So these are the questions that you ask yourself, and you get yeses for all those. Okay. So I'm going to go through this a little bit, sort of fast, I guess, but you'll kind of see the gist of it as we get going here. All right. So we're looking at here. So this is practice looking at this. Is the PRI normal? It is not normal. It is about 7.5 small boxes. Okay, so it's approximately 0.3 seconds. Okay, keeping in mind that a small box is 0.04. Okay, and we would like to have our PR interval generally about 0.2, so 0.2 or less. Okay. All right. So it is not normal. We have 7.5 small squares, so we have a prolonged P to R at about 0.3 seconds. Okay, what about the QRS? It is narrow. Okay. All right. So basically, this is first degree heart block. If we go through our little checklist here, we should just find that our PRI is prolonged. See what I mean? How this kind of just repeats itself. So that was like 15 slides of pretty much talking about the same thing. So again, the husband comes home late every night, and it's the same time every night. And this is just another little snippet of a slide from another PowerPoint. I think this is out of chapter, what chapter is this? Is it 14? Hold on one second. So this is out of chapter 11 in your textbook. Okay, so you have your textbook chapter 11 to be looking at your rhythm strips and also your EKG book. Okay, because you will be responsible for interpreting strips. I'm not going to be really particular on the rate, just as long as you get the rhythm right, and they're going to just be the basic ones. So hopefully don't get too freaked out. And I'm going to use ones that you have seen before, meaning definitely look at that banner guide that I have posted, that banner EKG guide. I may take some from there, or I may take some from your textbook. Okay, well, it's always kind of a challenge to find good, clear strips or examples of. Okay, unfortunately we don't have a lot of practice, because I'll try to put something together for practice, because I know I've done that before. In fact, I think they are actually at school. Yeah, I'll make a document for you guys, because I actually cut them out. And you guys had it was like a little matching game. Oh, these things are missing out on. Okay, moving on. All right, so now we're going to look at second degree heart block. Okay, this is where, back to our little story, second degree block type 1. Okay, so there's two types of second degree block. There's a type 1 and a type 2, but they're both second degree. So this is second degree type 1, which is your Winky-Bach. Okay, so the P wave, the wife, is waiting at home, and the husband, the QRS, comes home later and later every night. until one night he does not come home at all. Okay. Keep in mind that the husband, the QRS, must come home at least 2 nights in a row to see this pattern. So this is definitely more of a pattern. All right, so we have a progressive prolonging of the PR interval at the AB junction until the QRS is just dropped. Okay, it is less serious of the 2 second-degree heart blocks. So this one is less serious than second-degree type 2. The impulse is held or blocked at the AV node until it is unable to carry the electricity to the ventricles. So you have a P wave, but you just do not have the QRS. So that's where the husband doesn't come home. There's no QRS. Okay. So some P waves basically won't have a partner. Okay. So your ventricular rhythm is irregular, but your atrial rhythm is regular because you have the wife's there all the time, the P waves there, those march out, but then it just gets, the PRI gets longer, dropped. Okay, then periodically you just don't have a QRS. All right, so with that being said, then your atrial rate is going to be greater than your ventricular rate because you drop some of those QRSs. Your P wave has a blocked P wave at times. Okay, not always, obviously. So your progressive increase in the PR interval until a P wave is blocked. Your QRS is going to be narrow. And here is an example. Okay, so you can kind of see your P wave. I guess a little bit. We're kind of looking at the second group of them. You have what, about 3 squares there, 2.5, and the next one's about 3.5, and the next one's even closer to 5, and then the next one there isn't one. There's not a QRS, rather. So your AV node, some of the different causes is AV node ischemia, so that could be where the heart attack is, digitalis, increased vagal tone, electrolyte imbalance, complications of an inferior MI. Most of the time this can actually resolve without treatment. Otherwise, you need to treat the underlying cause. You may need to consider temporary pacing. So we need to observe this patient to see if they're going to progress into a higher form of a block. They actually will respond to atropine if the patient becomes bradycardic or if they become hypotensive. Okay, so here's kind of where we are practicing. We're looking at this and we're saying that our rate is about 60. Our atrial rate is normal and our ventricular rate is slower than the atrial rate. So again, your atrial rate is regular, but your ventricular rate is irregular. Your PR interval progressively is prolonged. So the QRSs look alike and normal, but occasionally are missed. This is very cyclic. Okay, so this is, I guess you call it regularly irregular. Right, so is the rhythm regular or irregular? Okay, it's considered irregular. A pause follows the dropped QRS, and the PR interval resets to the shorter interval, and then the cycle repeats itself. Okay, so you have that little bit of pause there after the QRS, and then it resets the cycle. All right, so these are all the different questions that you ask yourselves. You again have yes for most of them. However, is there a QRS for every P? No, there is not. That's where we drop that QRS. Is each P the same distance from the QRS? No, because that's where you're developing that longer dropped. All right, so our PRI here, this varies, okay? So it's getting prolonged. Our QRSs are narrow. Okay, so after we go through all of our little checklist, this is again Winckebach, okay, second degree type 1. Again, the husband comes home later and later every night until one night he doesn't come home at all. And here is another example from your textbook. So you can see the PR interval getting longer, kind of in that middle group, and then it just drops. All right, moving on to Mobitz type 2. So this is second degree type 2. In this one here, there's just an interruption in the electrical system near or below the AV junction. The SA node is working, it's just not reaching the ventricles. The PRI does not lengthen before a drop beat. Okay, it just drops. So when we talk about our little story again, the wife, the P wave is waiting at home. Sometimes the husband comes home and sometimes he doesn't. When he does come home, it's always at the same time. Okay, this is usually more serious than a type 1, a Winky Bach, and sometimes will require counseling, which they say is the pacing. Okay, so counseling is your pacer. Okay, so you don't have any kind of prolongation going on. It's just, he just doesn't come home sometimes. All right, so here is an example, and definitely here your ventricular rate is definitely a lot slower. Okay, so that's why you can tell that this is going to be a lot more, it's more dangerous. You have more of a decrease in your cardiac output. Okay, so your patient's more compromised. So this is a more serious dysrhythmia because it indicates that there's an increased risk of progressing into the third degree or complete heart block. The QRS may be dropped or not conducted. Sometimes it can be referred to as a ratio of P waves to QRS. Okay, so obviously your P's are going to be greater than your QRS's. So you can have like a 2-to-1 ratio, a 3-to-1 ratio. So the atrial rate again is regular. The ventricular rate is typically about 1/4 to 1/2 of the atrial rate, depending on the amount of blockage and the conduction. So obviously the ventricular rate then, looking at this strip, is considered Brady. Okay, so you only have like if this is a 6-second strip, which it's supposed to be, because you can see by the markings there, that's 3 seconds from the first to the middle, and then another 3 seconds from the middle to the end. That would just be, 3 times 10 is 30, so this would definitely be bradycardic. All right, so all these things that we're looking at, again, atrial is greater than the ventricular. You have more P's to QRS's. They're constantly normal. Sometimes they can be prolonged, but they're not going to get longer. Okay. All right. So when we look at this one, we say the rate's about 50. Okay. The rhythm is regular, and the fact that the atrial rate is regular, then you kind of have a little pattern kind of going on here. The P waves are present, and here's all the questions that you ask yourself. So is there a QRS for every P? No. But is the P the same distance from the QRS? Yes. Okay, so that's the difference there from the Winky Bach to the type 2 or second degree type 1. All these names get a little mixed up. So this is second degree type 2. I know what I'm talking about. I'm just trying to spit it out correctly. All right. So here, is the PRI normal? Yes. We only measure the ones that we can see. Okay, so we only measure the PRI from the P to the QRS, the ones that actually have a QRS complex. So they are the same. The QRSs are considered to be narrow. Okay, so this is, again, second degree Mobitz 2. All right, so again, our rate's about 50. It's considered regular. Our P waves, we have more P's than Q's. Our PRI is normal, and the QRS is also narrow. So again, sometimes the husband comes home and sometimes he doesn't, but when he does come home, it's always at the same time. So causes from this can be from damage to the bundle branch system following an acute MI. Treatment, you want to notify obviously the MD, hold any other drugs that can slow the AV conduction, and get ready for transcutaneous pacing. Also, you might consider dopamine if the patient becomes hypotensive. Caution with using atropine. It can actually increase sinus node discharge, but does not improve the conduction through the AV node. And this could actually create a paradoxical effect and slow the ventricular rate and then lead to further decreased cardiac output. And here is another picture. So you can kind of see how those P waves pretty much march out as normal, but we just lose the QRSs. All right, third degree heart block. Okay, so kind of analogy to our little story here. So the wife, the P wave, is no longer waiting at home. She and her husband are both now on separate schedules and they have no relationship and are no longer talking. Each spouse has a regular individual schedule. Okay, this frequently requires counseling in the form of a temporary or a permanent pacemaker. So they're each kind of doing their own thing. Okay, but there's no correlation between the two of them. So the heart rate and the ventricles may not be able to maintain a sufficient cardiac output to sustain life, and this can obviously be lethal. So there's no communication at all between the atria and the ventricles. The PR intervals will vary in length, and some P waves may actually be buried in the QRSs. Okay, so again, we look at the do our questions. The atrial rate is usually regular, and the ventricular rate is regular, but they just aren't jiving. They're just not matching. Okay. And again, the atrium usually fire more than the ventricle, so your atrial rate is going to be greater than your ventricular rate. Okay, so they're regular but they're each doing their own thing. The P waves are normal, but there's no relationship to the QRS. There's no pattern for the PRI. The QRSs are wide, but they can occasionally be narrow. Again, there's no relationship with the QRS with the P waves. If the QRS width is less than or equal to 0.12 seconds, it's controlled if the rate is controlled by the junction. Okay, so if your QRS width is normal, the rate is controlled by the junction. If the QRS is wide, okay, greater than 0.12, then it is usually paced by the ventricles. All right, so if we're looking at this one, we're saying that the rate is about 30. We have 3 QRSs there. It is considered regular. They're each kind of doing their own thing. The atrial have a regular rate and the ventricles have a regular rate, but they're just not communicating with each other. Okay, so we ask ourselves all of our questions, and we come back and we look at the answers, and we are saying that there is no QRS for every P wave, and is each P the same distance from a QRS? No. Okay. We will see a P for every QRS, but remember there's no correlation. Okay, it's not necessarily related. It just can be coincidental. All right, so on this one here, our QRSs are a little bit on the wider side. The PRI, on the last slide, the PRI varies. So some of the different causes of this are degeneration of the electrical system in degeneration of the electrical system in the heart, acute myocarditis, an MI, drug toxicity. Treatment can be atropine, isoproterenol, a pacemaker. It really depends on where the AV block is. So if it's in the AV node, then they want to treat with a junctional escape pacemaker. We'll actually initiate then the ventricular depolarization at a rate of about 40 to 60. When there are two separate pacemakers controlling the upper and lower chambers of the heart without regard to each other, then the situation is called AV dissociation. Okay, kind of an umbrella term basically is what they call that AV dissociation. It's really not a rhythm but a condition. So the P waves and the QRS are not talking to each other in the AV dissociation. So you have two different basically areas of the heart that are trying to control the rate. Okay, so when we go through this, we read this left to right here. We're looking at the rate about 30. This is just kind of recapping. The rhythm again is regular. There are no QRS for each P. The PRI again varies, or QRS is wide. Okay, so again, the wife and the husband basically have two separate schedules, and there's no relationship at all. Okay, they each have their own regular schedule, but there's no correlation. All right, so this is another little slide that I got from Wilkins. So again, no association between your P waves and your QRS complexes in your third degree or complete heart block. Your ventricular rate is slow. It's less than your atrial rate. Your atrial and ventricular rates are regular, but they're doing their own thing. P waves are considered normal, but they're not always followed by a QRS. The PRI interval varies. Again, no relationship going on there. And the QRS is generally, but not always, a little bit wider on the 0.12 seconds. Okay, so we're going to move on and talk about some bundle branch blocks. We have a few more slides here. So these are kind of some of the things that you ask yourself too, trying to figure out if it's type 1 or type 2 or type 3. So just looking at the PRI and all the complexes. So is the PR interval the same in all complexes? If it's yes, okay, then it's second degree type 2. Okay, no questions asked. That one is just where he just doesn't come home. It's just a QRS just dropped. Okay, but if no, okay, if the PR interval is not the same, then it's either Winkie-Bach, which is second degree type 1, or it's third degree block. Okay, or complete heart block. So remember, in second degree type 1, we have that prolongation going on. It's longer dropped. Okay, so the nights he comes home late, and then a little bit later the next night, then even later again the next night, and then he just doesn't come home. And then in the third degree heart block, they're each just doing their own thing. So the PRI definitely varies. Okay. It's just very random, the atrial and the ventricles, how they're beating. All right, so bundle branch blocks. These you need to confirm with the 12-lead EKG. Okay, your QRSs are generally wide, greater than 0.12 seconds, or at least 3 small squares, or 3 small boxes. You want to check this in leads V1 and V2, and you can generally see what they considered a rabbit's ear. We're kind of in that middle picture there. It looks like an M. Okay, so a rabbit's ear or an M shape. Okay. Sometimes if you look at, actually I don't see it on this one. Sometimes they can look just the R wave is seen a little bit smaller. Okay. All right, you may see this also in V2 and V3. So you might sometimes see it depending. You can kind of see it there in V2 and V3, the one right below it. So the signal, basically what is happening here is, so this is a right bundle branch block, okay, so RBBB. So the left ventricle basically depolarizes before the right, okay. So right bundle branch block, the right's being kind of blocked or delayed there, okay. So you have two QRSs and they're wide. So the signal has to travel to the left side before getting to the right ventricle. And this obviously takes more time. Because the right ventricle contracts a little bit later, the heart ejects a slightly less amount of blood. Okay, so a right bundle branch block, some of the causes, right-sided pulmonary hypertension, congenital heart defect, uncontrolled hypertension, and those listed there: acute heart failure, coronary artery disease with an MI, right ventricular hypertrophy, which is from right-side pulmonary hypertension, hypokalemia and a PE could be a cause. So with this, you obviously want to treat your underlying cause and consider a pacemaker. Now when we look at a left bundle branch block, the opposite's occurring. So your right ventricle is depolarizing before your left. And in here you're going to have a double spike QRS in leads V5 and V6. Okay, so just basically know what it means. That a right bundle branch block basically means that your left is depolarizing before your right, and a left bundle branch block, your right is depolarizing first. Okay, so some of the causes, again, can be ischemic heart disease, an MI, coronary artery disease, myocarditis. Again, you want to treat your underlying cause. Okay, I'll let you guys view this video on your own. It's kind of funny. It's just these guys basically dancing out and kind of showing the different heart rhythms. It's cute, but for some people it might click and make a little bit more sense, but I think overall it's just kind of funny. Alright, so now we're going to talk about ischemia. So this is where your ST segment is depressed. Okay, so you have basically an inverted T wave, right? So ST segment depression, okay, and you can verify that in different leads. So some of the causes can be cardiomyopathy and embolism. You want to treat with MONA, morphine, oxygen, nitro, and aspirin. Angioplasty, you need to bust up the clot. Bypass surgery. Okay, check leads. You want to make sure that there's, treat it, make sure there's no permanent damage yet, but you want to make sure that you go ahead and start with MONA. Alright, so ST elevation, okay, so that is an infarction, okay. So you have ST elevation, so your ST segment's going up, and that's the one where I was talking about how you're kind of going up to a different place perhaps. Okay, so you have ST elevation. You can see that definitely in V2 and in V3. You can see it also in lead 2, especially that second beat there with the Roman numeral 2. So that's where you want to call. So the other thing, when you see kind of like the outline of the fireman's hat, especially there in V4 and V5, it's kind of like the spiky part of like the fireman's hat. That's where they get that correlation there. Alright, so an MI causes any condition that myocardial oxygen needs outweigh oxygen supply. So the things that we need to do is, again, thrombolytics, angioplasty, a pacer, drugs, bed rest, oxygen. Okay, so we need to open up the clogged vessel there. Alright, so chest pain, these are things that you want to make sure you're evaluating on your patient. So time of onset, because obviously time is muscle. If we don't get in there and open up the clot, we're damaging the heart muscle. Provocation, what made it worse, what started it, when, did something bring this on? What type of pain is it, sharp or dull? Is it radiating? The area that it's in, is there anything that makes it better? Is it worse, or is it related all to your breathing? Scale, 0 to 10 pain scale. How long have you had it? And what do you think is going on? So these are the things that kind of the ODU technique. All right, just a little bit of humor there. Okay, so again, time is tissue, time is muscle. Treatment, MONA, thrombolytics, beta blockers, lidocaine, angioplasty, DORT balloon in less than 90 minutes, so an hour and a half. That's why it's really important to figure out when this all started, because time is, not time is money, but time is tissue. Okay, so this is a logarithm from ACLS on what to do. So you're basically looking at what's going on within less than 10 minutes. All these things need to be accomplished. Like I said, MONA is just an initial general treatment. Immediate general treatment is if you have chest pain, and you're pretty sure it's cardiac related. Oxygen obviously isn't going to hurt anything. Aspirin, want to make sure the patient doesn't have any allergies. If they're on any blood thinners, nitroglycerin, at the worst it might give them a headache. Morphine is going to help with the pain. So these are things, and EMS generally takes care of the MONA part of it if they come in by ambulance. So, and then we want to make sure that we've monitored our vital signs, checked our blood pressure, get our SATs, IV access, get a 12 lead, try to get a history as much as you can, make sure that they're clear for fibrinolytics if we need to, get labs on them, the different cardio markers, all their electrolytes, their coags, make sure they don't have any clotting, their clotting abilities isn't compromised. Like I said, if they're on blood thinners already, get a chest x-ray, hopefully within 30 minutes. And then from there, we look at the 12 lead to kind of see what's going on. If they're having elevation on the left side, you're assuming a new left bundle branch block or strongly suspicious of injury. So you have an ST elevation. So you're going to go ahead and start adjunctive treatments. No reperfusion delay. You want to get going on that as quick as possible. Okay, so meds, nitro, heparin, and then depending on how long it's been, if it's less than 12 hours, then we're looking at if we're going to do an angiograph, angioplasty, have cardiothoracic surgery backup in case they need to have a bypass. If there's ST depression or dynamic T-wave inversion, that could be an older MI. However, they're still at risk. So you want to make sure that, again, heparin, aspirin, nitro, try to restore perfusion. They may need to go to a cath. And if they're non-diagnostic, absence or changes in the ST segment or T waves, they need just to kind of look to see what other lab values, if they've got any other cardiac markers that are going on, do any other EKG, maybe consider an echo. So that's kind of the pathway. By this time, obviously emergency room physician or cardiology is definitely called in. Okay, I know that's a lot of information there. You're not expected to memorize a logarithm. That's just kind of for your information to kind of see how the thought process is and how they follow the protocol. All right, so pacemakers. So we're going to look at indications, symptomatic bradycardia. Symptomatic heart blocks are obviously not asystole as in true asystole, but if they're having pauses, okay? All right, so you obviously want to have the patient supine, having oxygen, IV access, EKG, and MD order. They generally start the rate at about 60, okay? There are, I think I did have a video on this. Let me see if I have a link on this page. You can, if there's not a link on here, no, I don't think I have a link. You can kind of YouTube it and see where they basically, what they're talking about with voltage increase until you capture the patient. So you want to, because I wrote myself a note here, video details. So what they're trying to do is they're trying to match those pacer spikes to the QRS complexes, okay? So that's when they're captured, okay? And when they're truly captured, you should be able to feel a patient's pulse. So basically the pacer is helping it fire and being synchronous with the QRS complex to give you a pulse, okay? So you increase that voltage till you can feel a pulse, okay? Transcutaneous, oh yeah, here's the little note I have. So transcutaneous, you're looking at 2 electroplads paced, one placed anteriorly, one posteriorly, or generally mid-axillary. The currents go through the skin. The heart depolarizes in a normal fashion. So if you look up YouTube transcutaneous pacing, open pediatrics, that's the one that I have showed in class before. So they're just pacing on a mannequin basically, and they're just kind of showing you how they increase the voltage, so they capture, then they back off one setting so they can kind of, not overshoot, but at the same time making sure they're maintaining a blood pressure. And then occasionally if they start to lose the pressure and they're not feeling the pulse again, then they might have to bump it back up again until something more permanent is placed, like a transvenous pacer. And so those leads are inserted through the vein to the right side of the heart. The electrical power source generates the impulses to the right atrium. It's a fixed rate and it's definitely synchronized. Okay, so then the other type of pacemaker would be a permanent pacemaker. This is usually an option when medications have failed. These are surgically implanted, and the generator and the lead wire into the heart. So you can generally see a paced rhythm because you will have pacer spikes. So you can have atrial pacemakers, ventricular pacemakers, or AV sequential pacemakers. So just depending where they place them or what part of the heart is damaged. And then those little kind of spiky things, I know it's kind of hard to see them, but there's like these straight lines, like a little tiny straight line right before the QRS complex, and that's the paced. Those are pacer spikes. Okay, there can obviously be problems with the pacer. Battery fails, runaway pacers, sometimes they malfunction, they're not capturing, or they're not failure of sensory devices, or they're not sensing like they should be. You still want to attempt to defibrillate these patients. Just don't put the patch or the paddles or whatever, don't put it directly over the battery pack. Okay, so just go to the side a little bit. Okay, hope that was helpful.